Now, the second question that I saw through the chat box, who was the last audio played by Dr. Richards? Now, that audio was of Professor John Ioannidis, who I would describe as the epidemiologist's epidemiologist, in the sense that he's the person that other epidemiologists run things by, and he's very prolific in all his work. But interestingly enough, since he described similar themes to what David and Joe have been talking about, he seems to be largely ignored by his colleagues for whatever reason, which is a bit of a pity, since seeing that he is one of the voices of reason in this discussion. Now, for all of you who are interested in data, so you could say how the data is readily available. Now, David's work is based, as he mentioned, largely on the Euromomo data and a few other references which he mentioned. If you're looking for a similar interpretation of, or a similar look at the data from a different interpretation, as this one here, which came out sometime last year, and this was through the Lancet, I believe. Their analysis came out much sooner in terms of releasing this, so it doesn't have the last more than 9 months that you could see in David's data. But essentially, they had one variance in terms of how they, in their conclusions, in the sense that they had one phrase where they seemed to find that the recovery of certain patients was better in places that had more stringent closures. Now, how that was exactly calculated, I was trying to figure that out, but it wasn't extremely clear to me. But in every other parameter, this research team, which had their work published at the Lancet, came to pretty much the same conclusions that David did. So if you're interested in different perspectives, and all three of us and our whole team and HRA absolutely encourage you to look at a wide range of information and data from people, particularly from people that don't feed your pre-existing biases. I think that's the only way that we learn. When we had I put a bit of a subliminal there in terms of early on before the presentation to think through about what's been occurring under these parameters. From looking at what David was presenting, if we look under these headings, and what I gather from the data comparative from various countries, just to put it simply, the severity level, now this is very difficult because it's extremely variable from people who are asymptomatic up until severe respiratory distress, if you consider that to be the worst thing, because, well, death is multifactorial, so it's really hard to say whether that is the end point that well, you could say it is though. Secondary infections and severe respiratory distress, I would say that those are the sort of parameters that you'd be looking at, but the extreme variability with respect to the host being the dominant factor as to outcomes. So that's one aspect. Complications variable, you would have read and heard about a lot of these things. That's no different from any sort of viral infection in the sense that there will be things that some people experience out of the ordinary following infection. So it's a bit, again, it's hard to go, you can go into that into as much depth as you want. We know the transmission is highly contagious. That's one parameter to consider. And we look at proposed interventions, and this is where, if in doing any sort of medical intervention, you would have to ask yourself, when you're doing anything that is a form of treatment or investigation or intervention, you have to ask yourself, what is the outcome that you're trying to achieve? And from the data that, from the previous presentation that David did, we can pretty much confirm the equivocal nature of lockdowns. And we put a question mark there in terms of how much exactly do vaccinations change infection rates and severity rates. And that is a very good question if you have a scientific mind in terms of putting up as a question for inquiry, because you would want to know, does this treatment actually help? Is it equivocal? does it harm? And I think that's the standard that we have for any sort of treatment. Now, the other part here, of course, is when you're doing any sort of intervention is consider the consequences. And this line of thinking about second and third order effects. What else happens when you provide an intervention? And now I'll leave that for you all to think about in that from there. Now, there's one part that gets missed. So let's just say we'll change the parameters a little bit. Let's say it was severe for everyone, which some people believe that. And I don't understand that belief, but I can appreciate it, especially if you're in a high-risk group. Let's say it was very severe. Let's say it had lots of complications. Let's suspend reality for a moment and say that the interventions actually help, that people got less infections from doing this and from lockdowns. Is it a good idea, if something were highly contagious, is it actually a good idea to suppress it? Knowing that eventually you will have to face up with this infection and be exposed to it at some stage. More than 10 years ago, Professors Ted Cohen and Mark Lipsitch released this study giving which they titled the Too Little of a Good Thing, a Paradox of Moderate Infection Control, which pretty much described the non-desirability of the delaying effect on groups that are not at high risk. This is a difficult discussion to have because everyone's risk is, again, it's individual, but the idea that suppressing infection in order to someday either avoid the world or to gain some form of immunity at a later date through other means is contentious at best and probably harmful at worst. So now hopefully we've got some questions in, but if we haven't, okay. Now opening the floor to, if you can unmute yourself, David and Joe. So I apologize, there's a lot of questions and we won't be able to go through this. I think we will need a special, a different Q&A almost for things that are out of the, so the first question here, let's just shoot to either of you who want to answer, David or Joe. If the PCR testing is positive or negative, how do we know what strain it is? And can you summarize a little bit about PCR testing credibility? I think you did that through your presentation, but maybe in a few words as to what you think, how much reliability do they have?
Sorry, is that Yaska Mirif or?
Yes. That's
yeah. Look, I think if a patient comes to a hospital with a suspected infection, then PCR can be very, very accurate at identifying or confirming that infection. But if you're doing millions and hundreds of thousands or even millions of tests, then even the best testing system is going to have error rates, and those error rates are just going to become compounded. So the more PCRs you do, the greater the contamination in the system and the more of the false positives you're going to get. Now, one thing I didn't touch on there was that the other thing that is patently obvious with PCR testing is that you've only got a very narrow 5-day window of picking up a positive result. If you're outside that 5 days, say you're day 2 of your infection, you'll test negative on the PCR test. And then say you test yourself a week later, say at day 10 or 11, you can test negative again. And your opportunity for being detected on PCR is basically, between about day 5 and day 10. And then after that, the sensitivity of the test drops dramatically to about 20-30%. So when people are testing themselves repeatedly over and over again, unless they, the test is almost worthless unless there's some kind of symptoms attached to the test. The other problem with PCR is that there's questions about the fidelity of the PCR to the presence of the virus. For example, say the Delta virus mutates, and you've got new mutations in the area of the genetic code that the PCR test is picking up. Well, then that will alter the sensitivity of the PCR in detecting the presence of that strain. So again, that can lead to false negative tests. So once you start doing this kind of testing on a continual basis, it's close to tossing a coin as to whether literally you just about, when you're doing 100,000 tests on very, very low rates of infection, then basically it's almost like tossing a coin as to whether it's going to come back positive or negative. Now that's not to say that it can't be useful if there's an index case and you want to test people around that to see if they've got carrying infection. But where it's being misused is when you're asking people to just drive in to have tests for PCR randomly as they drive through the city and all the rest of it. Then the disturbance you're creating in people's lives based on a test that's got very, very low value indeed it doesn't make sense. It's absurd, really, to be honest. It's the only way I can describe it. Does that answer the question?
I think that does answer the question, David. Question for Dr. Joe. How can we make it clear to government we do not support the rules being imposed? Now, you've spoken a fair bit about this in recent months. I think you have a balanced perspective on this. Would you be able to help this person?
Yeah, look, I think petitions write to your member of parliament at a state and federal level. Encourage all your friends to do the same. I was told many years ago by somebody who'd entered parliament that, and look, this case might be slightly different. He said, look, if he heard about the same issue from 3 constituents, that told him that it was a hot issue out there. So I think the politicians who are all poll driven, they really are poll driven, and it's been come to a circle. Government's told everybody that lockdowns keep everybody safe. Everybody sort of feels safe, so they think it must be due to lockdown. So it's a closed loop circle, but they continue to do it because they believe it's popular. So if enough people write to their member of parliament and say, we don't support this, show us the science, show us the data, so they start to get thousands of letters and emails, and all individually. Like if it looks like it's a mass thing from a change.org, I'm not sure that will have much impact. And quietly talk to your friends and just sort of say, what do you think about this? Have you, I'm interested. You support lockdowns. Have you got any papers you can share with me? Not attacking their view, but yeah, contact your local and federal, state and federal member of parliament and encourage like-minded people to do so. And ask them for data, ask them for where the trials are on lockdowns, ask them for where the data is on masks, ask them for what they're going to do about the harms. Look, it's not all going to change by tomorrow or next week, but, cliche, Rome wasn't built in a day. I think that is a way to go about it. And where you think it's appropriate, talk to your friends and family as well.
Thanks, Joe. No, this one's a little bit, I think it's we do want to have more vaccination type questions in coming weeks, but I think this is one that I think needs to be thrown out at the moment here in terms of analysis of adverse effects of vaccinations. And I'm trying to, because there's a few questions that look quite similar. Basically, this is the question is trying to address knowing between, in the same way that if something is from a virus, the effect was from the virus versus something's coincidentally happening after vaccination, or is it a vaccine adverse reaction? I'm trying to amalgamate a few different questions there. Do both of you get the gist of the question?
Yeah, look, I mean, essentially it's thought that, 50% of death certificates are wrong. So look, that sounds a bit of a strange place to start. But you know, correlation is not causation. That something happens at a point in time and something else happens at a point in time doesn't mean that one has caused the other. The classic, and this is an inverse, people with multiple comorbidities who happen to have COVID are all classed as dying of COVID. Maybe they died of a heart attack or stroke or a whole host of other reasons that was already wrong with them, and they had COVID at the same time. So there's been a tendency to ascribe all of those deaths to COVID. Flipped the other way, when people have had problems with the vaccine, and they do, no medical intervention is 100% safe. No medical intervention is 100% safe. There's a tendency to say, oh, well, it wasn't really due to the vaccine, it was due to their underlying medical problem. So the exact opposite tack is taken. Whether they all get reported or not, I think that's unlikely. How many are actual effects and how many may have just happened at the same time? You can never actually work that out. But I think the approach to want to ascribe all deaths for people who might test positive to COVID, ignoring their other comorbidities to COVID, is the exact opposite one that's taken with vaccines. And I really want to emphasize they are safe. You know, I've had them, I'm still alive, but nothing, as I said, from paracetamol to penicillin to any medical intervention, nothing is 100% safe. Everything has potential side effects. And that's why it should be to the individual to decide, do the benefits for this outweigh the risks to me, not to the next person, but you know, to me.
Thanks, Joe. All right, I think we need to, sorry, David, you go.
Sorry, there's a couple of questions that came up. I saw that why do you think we are testing much more than other countries? We've got this elimination policy in Australia, and it's madness. You know, you know, we're intolerant of the virus, and it's a dead end. It's a dead end progression, and so they're trying to eliminate the virus, and I obviously I don't know how that's going to possibly be a sustainable path forward, to be honest. And another question was, so the vaccines have very little impact in reducing mortality for those under 50. It would appear so from the Public Health England that the effectiveness of the vaccine in terms of protecting against mortality certainly reduces infection rates, but whether it has a significant impact on mortality rates below 50 in the vaccinated and unvaccinated from Public Health England in relation to the Delta variant were very similar.
Thank you.
And look, I'd just probably make a minor point about variants, because every time there's a new one, it's another sort of, you know, shock horror moment for the media, and you know, everyone is nastier than the one before. Viruses mutate. This is not actually new. Viruses mutate. They always do it. And this particular strain, we've got to remember that COVID is a coronavirus. Coronaviruses typically cause a cold-like illness. And they mutate and they change. And if anything, despite all this noise about the Delta one, which is the current one, there'll be another one, you know, next month, and, you know, so many months later. Typically, as viruses become more transmissible, they become less lethal. There will never be a pandemic of Ebola, because Ebola kills most people that get it. So it doesn't spread very far and it doesn't get passed on. Equally, the common cold is highly contagious because it doesn't kill anybody, and so it gets passed on. So, you know, we need to move, and David's completely correct. This approach to elimination is completely wrong. It cannot be done. It'll never happen. So we need to focus not on how many positive tests there are out there, including the fact that some may be false positive. We really need to focus on how many people are in hospital. How many people in the vulnerable group are suffering? And so far in New South Wales, there have been 10 or 12 deaths. Last year in Victoria, there were 800. What we're seeing is those that are in the high risk category are not dying as much this year. And yet somehow we're told that Dan Andrews was the master of COVID, and yet the death toll in Victoria is more than the rest of the country put together by a factor of 2 or 3-fold. So we do need to change our focus to protecting the vulnerable rather than this raw number of positive tests.
There's a good question here from Mark saying about why are we using PTS if it's so faulty? I understand New South Wales uses high cycle rates. And that's true that many of the, if you're using the cycle threshold is a term used to describe the number of times that the signal from the virus is amplified. And once you get up to 38 to 40 amplifications, then the evidence is that there's very low likelihood that the presence of whatever you're detecting is correlating with a real virus present. It's probably, a little bit of a remnant DNA or something like that. And so, but some of these are being classified as positives, even though it's almost certain that they're not going to be actually correlating with, a virus that you can culture or grow or find the presence of. Yeah.
Question here that I thought was interesting, and of course, with respect to the person who asked the question, again, we're not giving individual medical advice, but it's a good question because she asked that she's 86 years old and reasonably healthy. But her question is, what is the risk with this current strain compared to, say, last year's strain for somebody in that age category?
Well, I can tell. Probably it's probably around about 5%, something like that. But 5% mortality risks, case fatality rate 5%. But you've got to multiply that by the prevalence of the disease. So I think I calculated, your risk of actually dying because of the low prevalence of coronavirus in Australia. Your risk of dying from contracting coronavirus is about 1 in 600, based on the multiplication of the mortality rate and the prevalence of the infection. But I think mortality rates start to get quite high when you get I correct myself. They'll probably be nearer 15%, maybe 20% if you do get the infection. So there is benefit.
Compared to last year, though, compared to last year's strain.
Look, I haven't got solid enough data to give you an absolute figure, but I'd say it's somewhere around about if you get infected, it'll be between 10 and 20% mortality based from this Delta strain, I'd say, in that age group. So vaccination does make sense in that in an older age group, but you've got to temper that with the prevalence rates, which are very, very low. So your chances of picking up coronavirus in the first place is very, very low. And remember, vitamin D will, if your vitamin D levels are adequate, then that will give you substantial protection as well. I don't think you can underestimate the risk of the virus once you get above 80. It's also important to remember 94% of all deaths in Australia are in people over the age of 80. So I think that
we do have quite a few questions regarding pre-treatments and effective treatments, and I do apologize. It's a bit out of the scope and time for this presentation, particularly because we also intend to have particular doctors who have expertise in those matters, which I don't know as much about that, and I don't know if David and Joe have particular interests in those things, but there are other people who do, and hopefully we can get them on board to speak about those types of questions. Autumn, question, what's the people who have hands up? Do they want to make a video appearance? There's 3 people on the very top end that have yellow hands.
Let me just unmute one of them.
To say something, yes?
Yeah. I'll find you. Hang on 1 minute. Yeah, I've just requested that you unmute if you'd like to ask a question, because
Yeah goes first. Yes. Okay. Excellent.
Yeah. Hi. Thank you for your time. I just wanted to give you the general topic of my question before I ask it, just for you guys to decide if it's related to this stream or not. My question is in regards to asymptomatic patients. Can I ask about that?
Yeah, sure.
Okay. So the general what they're pressing in the media for, like the lockdowns and the masks and stuff like that, is in regards to asymptomatic transmission. Whereas listening to some of the top immunologists like Dr. Michael Eden from the UK, for example, and some articles. And also, like, if you go through general flu websites, there's never been really a case where asymptomatic infection has been something of concern, of great concern. What's your opinion in regards to asymptomatic infection being like the deadly cause for this pandemic?
Well, look, there was an interesting. So I'll just touch on some of the work of Edgar Hope Simpson, because well, one of the things that he looked back at the history of these seasonal infections like influenza and coronavirus, and he went back to the time of the Spanish flu, and people after the Spanish flu, they got some subjects that were infected with the, this is the 1918 flu, and basically they got a few patients together, and they took the secretions, the mucus and the gunk from these patients, and put it into a bit of saline, and they aerosoled it, and they tried to infect patients. So this was a study they did, which you wouldn't be able to do this study today. Basically, they took these volunteers and took all the secretions from these infected patients from this flu, and they tried to infect these patients by spraying the mucus from these infected patients straight into the face of the subjects, of the volunteers. And no matter how much they tried, they could not transmit the infection from the mucus and so forth. They could not transmit the infection in this flu infection into the volunteers. And that gave Edgar Hope Simpson the belief that viruses go through a life cycle, and so there are moments where replication is a high energy event. It takes a lot of energy out of the virus, and it wants to optimize its chance to spread. And so what you find is that the virus will multiply extremely rapidly over, talking about billions of particles over, well, maybe millions, certainly anyway, over a very short space of time. And during this acute phase, that's where the vast majority of infection is going to spread, through these acute phases like coral blooming events. At least that's according to Edgar Hope Simpson, who's a highly respected epidemiologist. And so, based on his descriptions, I would say that, that Michael Yaton's suspicions are a fair representation of the likely kind of scenario, and that the possibility of asymptomatic transmission in the open is extremely low. Extremely low. I can't say it's zero, but it's extremely low.
Look, I think this hits on a whole key point, that we seem to have reached a point where no amount of risk is acceptable. Now, if we did that, we'd never get in our cars. We pretty much wouldn't get out of bed in the morning. I mean, at a very simple, intuitive level, people get a cold. Often, if you get a cold, you live in the same house with other people. It's uncommon. In fact, in my experience as a GP, it's very rare that everybody in a household has the same virus at the same time, whether it's flu, whether it's cold, whether it's gastro. People might get it sequentially. You might have 4 or 5 people living in a house. Not everybody gets it. Now, what that means is either A, people might be getting the virus and having no symptoms. They might not be picking it up, or they might be picking it up and developing immunity and not getting any symptoms and developing immunity. So the concept of asymptomatic transmission sort of says, well, can the virus be passed on? Yeah, it probably can be. I'm sure we can't prove that it isn't. The bigger question really is not that. The bigger question is, well, really, does that matter? If somebody has no symptoms, can they pass it on to somebody? Look, is that possible? It's not impossible. It really just comes back to protecting the vulnerable, because they're the ones who are at risk from infection. If other people pick up a virus that they don't get symptoms from, well, that doesn't really matter. So again, the focus needs to be on protecting those as best possible who are at most risk, and everybody else will get better.
Thank you. Silvana, I think you have your hand up there.
I've just asked to unmute you, Silvana, if you'd like to ask your question. If you're able to do that. Silvana, you with us? Possibly not.
What about
reach out to me if you want to ask a question, and I can unmute you again.
temporarily was another gentleman with the hand up earlier, but seems to have disappeared. Ellie, can you unmute our colleague, Dr. Ellie Lazar, Autumn?
Sorry, how do you spell that name? Then I can search for it.
E-L-Y.
E-L-Y. Oh, yeah. I've just asked to unmute you, Ellie.
I just want to make a point, David, about how ludicrous this this testing is. I don't know if you heard, there's a professional golfer in the US named John Rahm. He was leading a golf tournament going into the final round by a substantial 6 strokes or something. He tested positive just before the final round. They had to pull him from the tournament. So he lost $6 million, $5 million basically. Then he went on the following week to win the US Open golf. And then the week after, he tested positive again. So they pulled him out of the next tournament. And yet he never had COVID.
No,
So,
unbelievable. No,
yeah,
shocking. It's shocking.
It's crazy. It's actually crazy.
Yes, it's right. Something out of Gattaca. Oh, it's unbelievable.
Yeah.
Yes, thank you. Thank you. Silvana looks to be on there.
Yes. Sorry about that. I wasn't sure if you were taking raised hands or not, so I just texted earlier. I was just wondering about the antigens. Before I came back from the United States, I had an antigen test done as well as a PCR test, and it showed that at some point in the last 12 months, I must have had COVID because I tested positive for the antigens, but negative for COVID. So if the whole point is supposed to be about herd immunity, and if so many people are supposedly becoming positively infected without actually getting sick, why are we not doing the antigen tests to show that people do actually have the immunity bug like I do? Isn't that relevant? And thereby no need for a vaccine?
Do you mean antibody test? Antibody test?
Yes.
Antibody. Yeah.
Isn't that what an antigen test is?
Well, yeah, yeah, yes, so, sort of. Yeah, test sort of. Yeah, that's right. Well, basically, the antibodies are actually the immune response to the antigen, like the B cell response. They produce antibodies, and so most infections. You find that it's what we call adaptive immunity. The immune system responds to the presence of the infection, and then it produces these antibodies to kill off the infection. And so the antibody tests are helpful in confirming exactly right that you've had a previous infection, and so they do have value. But the thing to appreciate as well that these kind of viral infections are often controlled or responded to but through T cell immunity. And so you can develop T cell responses to the virus, which still give you solid immunity. In fact, more reliable immunity than the antibody tests. And of course, that won't show up on an antibody test because the antibodies test the B cell responses, the antibody responses, not the T cell epitopes, as we call them, the characteristic. They're much more difficult to test for in routine settings. So yes, antibody tests are good, but they do miss a lot of previous infections. So people can have negative antibody tests but still be immune to the virus.
Okay.
Thanks for your question, Silvana. Jayanti.
Yeah, I've just asked to unmute you, Jayanthi. You should have a notification.
Yes, thank you. Thank you for the presentations. They were really good. David, I have a question. The VAS data seems to go all over the place and it's notoriously underreported. So I'm asking for when you estimate the death from the vaccination, you know, like the numbers may be fudgy, and a lot of that, in a sense, I think it's pretty sinister that Facebook is people who have groups where they talk about vaccine adverse events, they're being silenced, and we're coming to a point where they're silencing people who report adverse events from vaccination. So I was just, you know, I just have a bit of a criticality towards the data where in terms of the risk and benefits of vaccination in that sense. And yeah.
Yeah. Do you want to say that one? No. Look, it's I mean, it's so hard to get at the you know, this is where we should be getting, you know, solid peer-reviewed articles to really tell us, you know, what the true effect, you know, what the true mortality rate is. You know, the European Medical Agency also keeps a repository of vaccine deaths as well, and they, you know, if you I did see a publication from the 27th of, I think it was about 27th of May, where they reported on the mortality rates. The EMA, that's the European Medical Agency, their CDC, Center for Disease Control, and they reported that the mortality rate, and again, I don't know, I can't verify this, but they reported that the mortality rate was about 4 per 100,000. But you know, yeah, it's impossible. The truth is, it's actually impossible to verify the numbers. And of course, the other problem is that you know, in these repositories, you need somebody to go in and actually look at the data and find out, you know, what was really attributable to the vaccination and what was you know, sort of just temporarily related to the vaccination. And unless somebody does that kind of clinical research, you just don't know what the truth is. Yeah.
Thank you for the question. There's been one that hasn't been answered yet. I'll just read that to you. Is there evidence that vaccination does reduce transmission? Sorry, that's the whole point that the campaign is based on, with queries about the passports, etc., that an unvaccinated person is at greater health risk. Did you want to comment? I think you had a few slides based on regarding this question. David, do you want to summarize?
Yeah, look, I did. Yes, there was. I can't remember exactly by how much, but there was evidence that the vaccine was reducing transmission rates in Europe in May and also in America at the beginning of June. So definitely there was evidence, but of course that was what it was particularly reducing transmission rates of the Alpha variant, and so of course that statistical association diminished in June and July when I looked at the European data there. Now, whether that's just because I haven't got enough power in my analysis to be able to pick that up, or whether, you know, but yeah, look, I think the reality is that you know, certainly from the AstraZeneca studies, when they looked at virus shedding, which is, you know, sort of a good measure of reducing transmission. The AstraZeneca vaccine didn't have any effect on viral transmission, and also that wasn't even studied in the Pfizer study. But I think the words from Brendan Murphy were really important. You know, he said that he said that they'd achieved the aim of vaccination, which is to protect the elderly and the vulnerable. And I think that's what vaccinations can do. They can protect people who are at higher risk and are vulnerable to the illness. And I think that any effect on the transmission of the infections well, the figures I showed you in those slides, to put, I don't know whether you noticed, I can bring it back up actually. I'll try and bring this on. I can't. Sorry, but this one of the slides showed the information from Europe in terms of how many infections it would stop, and the vaccination from the data in Europe, even with 70% vaccination, 60% vaccination rates, as we're seeing in Israel, from memory, it would stop 188 infections a day based on the European data. But also, according to the European data, based on the prevalence, that was based on a prevalence rates of 2,700 infections a day. So in other words, from the European data, what I saw was it would 60% vaccination rate would prevent approximately 200 cases out of 2,700 daily cases, something like that, which is not a lot. An effect, fairly small.
Thanks, David.
Seeing in New South Wales this year compared to Victoria last year is a lower rate of fatalities in the risk group, and that includes mainly over 80s and those in aged care facilities. And that's because I think 40% of those have already had 2 shots, and I think something close to 80% have already had 1 shot. So this comes back to this fundamental problem, in my opinion, in this country, that we keep being focused on the number of positive tests. Again, the extreme. Ebola kills people. If we had a virus that caused an itchy finger for a day, nobody would care less how many people got it. You know, I know it's an extreme example. So the number of people who get a mild illness doesn't matter. The whole point of response to COVID was to flatten the curve, and that wasn't to stop people testing positive. That was to mean that cases that were serious, that required variably hospitalization or ICU, would arise at a rate that the health system could cope with. That has clearly been achieved. If people get a mild illness that really, in my opinion, doesn't matter, if severe illnesses can be significantly reduced, and it appears from pretty much all the information around the world that is happening with vaccination, it's not eliminated, doesn't mean nobody will ever die as long as, the world is spinning, then, that's really what it's about, reducing transmissibility. Just again, if we're not getting serious illnesses, is not, in my opinion, a primary consideration.
Thanks, Joe. I do apologize. There's a lot of vaccination related questions, and we will have to make a separate forum for this, because I think they deserve the depth and enough description to answer these questions that wouldn't give them justice just by skimming through them. I do notice that 3 Angel does have a hand up.
I've just unmuted you.
Yeah, thank you. Thanks for that. Hi, Dr. David and Dr. Joe. That was an excellent presentation. So thank you for that.
Thank you.
I wanted to ask, I am undecided on the vaccination because I understand that it's very new and I'm still doing my research. I understand that vaccines take, up to 7 to 12 years before we can get all the safety data. And like I think one of you mentioned, it's only been approved for emergency use. So it's still under provisional approval. I'd like to know what current treatments we have available for COVID right now, and are you prescribing, like I've heard about ivermectin, and I know there's a lot of research on hydrochloroquine. Are you prescribing, or what treatments are available, and are doctors in Australia able to prescribe these treatments? And what have you seen in your practice?
Sorry, David, unless you want to add something to this particularly, that's a great question, Angel. There actually is a fair amount of effort being considered for this. And I think if you contact HRA, we may be able to direct you in the right direction, hopefully, and see whether it's appropriate for you. there's certainly things that we need to take into consideration. And of course, because you're an individual and you have your own unique physiology and medical state, then that would have to be discussed with a doctor who knows you, who will take a thorough history with you. But yes, we can direct you to the right places. David, did you want to add?
Look, I've not even seen a case of COVID in Queensland, to be honest. I think I sort of frog with COVID, but apart from that, I haven't seen a case of COVID. So I've got no clinical experience with treating COVID patients, because we haven't seen a single case in Queensland, or in my area of Queensland.
Look, I'd have to say the same. Look, typically there are no, with a couple of exceptions, antiviral medications. There's no medication that you take for the common cold. There's no medication for the flu. Tamiflu reduces at best the duration of the illness by about 18 hours. You know, it's not a cure for the flu. Whether hydroxychloroquine or ivermectin, how effective they are in what circumstances, all of those is really, there's a lot of debate and argument about that, and I express no opinion, other than to say, you know, for people with severe cases, it's difficult to argue as to why they shouldn't be able to try it. But you know, powers that be are against that. But they're generally, with viruses, it's not like with bacteria we have antibiotics. There are only a handful of antivirals in only very certain specific cases. I'm with David, I haven't had any experience in that field either, and really can't express any opinion.
Thank you. Before we, I know that there's, we've run past time, and that I think our organizers and admin might have to go. I just wanted to, and I know we have got one question there as well. I just made a third slide because I didn't know how quickly the Q&A would go and everything. And to your friends and colleagues who are unsure about what I think sometimes there's a lot of preconceptions with this topic, that people think that something is either that the messaging that they have been getting, they presume that to be true. I think at the very root of it, there's a few factors as to why we got here. And both Joe and David did mention this in passing, but I thought it deserved its own slides. And it basically comes down to this, that this is, of course, all of you will know these numbers. And these are based on modeling from the same people who did the imperial modeling for the current situation. They're quite impressive. So 2001 is hand, foot, and mouth disease. 2005 is bird flu. 2009 is swine flu. Now, I'll make an offhanded joke to say that you probably wouldn't want this person to be your investment manager or your employer or anything of that sort, but that's not fair to I think the issue here is not to disparage our colleagues who put the hard work into doing modeling, because modeling has its place. And this doesn't really have much to do with severity either, because you can make the argument that there will be a day where some infection comes in and sweeps the world because of all the pressures that are faced in the environment and on our genetics, etc., that you can make the argument that something will happen of a significant severity at some point. The challenge is this with this particular, well, you could say for one is that, to put it very lightly, is that the person is a bit of a doomsayer, maybe, or you could say they're a bit of a genius because they had such high impact in terms of reducing these outcomes. I suppose or if you were cynical, you could say that the person who sells you the problem also sells you the solution. So it's a little bit like getting your fortune being told by somebody who runs those types of things in the street. No offense to people who do that sort of clairvoyance work. But that's not really the point. Okay, let's just say the current situation had the severity that was predicted. That's fine. The issue here is two things that I'm not sure whether our colleagues, whether a lot of people who talk about these issues are aware that. Number one is that these models were being used to implement policy that had never been done before. So they were taken as supposed expert advice, but that's not the issue either. The problem, there are many problems that come with this. One of them is that the modeling, if you actually look into it, neither had the accuracy nor the precision, meaning to say that the code that was run was not replicatable. And Imperial don't even want to release the original code because, well, you'd think that something of this magnitude, you would double check it with other organizations that, so let's say the insurance industry are very good at modeling. David does advisory for these types of modeling companies, and they wouldn't use this type of prediction. And you can easily tell why. If a model does not have accuracy or precision, then you question what's the point of the model, and you say, okay, it's helpful. Let's leave it at that. Let's just say that the severity is there. Let's be generous and say that the modeling, that the accuracy and precision is not as bad as it seems like. Okay, we'll give two very generous offers there. But the third problem, though, is that the mitigation measures are based on conjecture. So the data that was put in was basically saying that if you do X, you may get Y, and repeat that by 100 or 1,000 times, which is why the models are not replicatable. The issue with this here is that when people quote D-science, something that Joe mentioned earlier, a lot of people are actually referring to this without knowing that this is what they're referring to. When politicians say that they're following medical advice, when your peers or your colleagues or whatever will say that they're following expert advice, they're basically saying that and again, I'm really not denigrating the people there's a lot of hardworking, good, compassionate people who do these models. The problem, though, is that if you ask a person who has a certain expertise to extrapolate their expertise to an area which is very complicated, the chances that the person who asks the question will extract the conclusion that they want, which is independent of what the person whose question has been asked of them, becomes significantly higher. I can give you a lot of examples of this, but we're quite a bit short of time on that. But so when people talk about, so the biggest thing that I think I wanted to emphasize here is that the comparisons were done with if you had done nothing, which means that if we weren't aware that such a virus existed, therefore we were letting people go in and out of hospitals, of wards, and all the healthcare workers were getting infected, then you may see these dramatic outcomes. Now, the problem here is that the models didn't account for the fact that pandemic plans were already in place. People know how to institute measures to protect themselves, that many people would have reduced patterns of movement anyway if there were a significant threat. And that most of societal movements are predicated on individual movements that have not much to do with external measures. So they were comparing basically between, it was almost like the model was based on 0 versus all, which is just not a realistic estimate. So there's 4 different levels of failure there as far as the model goes. So when your colleagues mention that, this is what they're referring to, and many people don't even know that this is what they're referring to. Meaning to say, like, you could put simple things like mask wearing, distancing, etc. They were assumptions based on what they input into the model. A software analytic group made the claim that this imperial model could be the most devastating software mistake of all time, probably, as far as, or maybe more to come if we take this as models for the future. Professor Gajewski from the European Center for Disease Control says the most influential scientific paper in memory, and sadly one of the most wrong. The reason why I think many of us are concerned enough to have these types of presentations is that it's not so much about today, because what's happened in the last year can't really be reversed. Well, it can't be reversed. The issue here is, what precedent does this set in society? How do we deal with the problem of the fact that we will have many other contentious issues in in society to come, infections or otherwise. And I think it's very difficult for people to extract themselves after such bold claims such as these. It's very difficult for people to extract themselves from this. And I think as far as a society and as far as the medical community goes, is that a little bit of humility and a little bit of accepting the fact that we are very fallible would go a long way in mitigating the sort of thinking errors that we've done for the last year and a half. That was my end part. Elphone, you've got a hand up. Can we unmute?
I've just unmuted you, Elphone.
Hello. Hello. Hi. Hello. I'm Louis' wife, Lena. I just had one question. Hello.
Hi. Please go through.
Yeah. Okay. You can hear me. I just had one question. It seems to be unsure to me with all the literature I've read, peer-reviewed literature, which cells actually uptake the vaccine and produce the spike protein on the cell surface. So it gets injected into your arm, but then which cells are actually taking it up? Because in a traditional vaccine, we have the dendritic cells take up, the virus that gets injected into you, and they express it on the cell surface and it initiates an immune response. But what's actually taking it up? Because the spike protein, it's unclear which cells are going to be expressing that spike protein on the cell surface. Is it our endothelial cells? Is it our blood cells? Is it our muscle cells, our parasites? Which cells are actually expressing the spike protein on their cell surface? Do you know this? Because it doesn't seem apparent in the literature. Did you hear my question?
Yes, I might defer that to you, David. And you're muted though, unfortunately, David and Joe.
1 minute. David, you're unmuted now. And Joe.
Yeah, thank you. Hello, can you hear me?
Yep.
Yes, thank you.
Sorry, the question was about, so I missed the first part of the question. That what was the—
Which cells will reuptake vaccination?
So which cell type will express the spike protein on their surface? Once the vaccine's injected into it and the nanoparticles make their way, which cells are absorbing the nanoparticle and then going to transcribe the mRNA and express the spike protein on the cell surface? We don't seem to know which cell types it is. That non-specific, whatever cells the nanoparticle makes contact with, or is it specific cells? It doesn't seem very clear which cell type will express the spike protein.
Well, there were no tissue distribution studies done on the vaccines, and so there is a paper there's a paper published in Japan, and they did look at tissue distribution for the vaccines, and now because my kanji is a little bit rusty, so I had to rely on secondary reports of the papers. I haven't read the original paper myself, but from what I understand, it's quite widespread distribution of the Pfizer vaccine through.
It could be your endothelial cells, parasites, your capillaries, anywhere.
Yes, from my knowledge, certainly the ovaries, the liver, endothelial cells, cardiomyocytes, and of course brain tissue as well. Quite extensive.
Brain tissue as well.
Yeah, crosses the blood-brain barrier apparently.
The nanoparticle can cross the blood-brain barrier.
Apparently so. Yeah.
Of course it can, because these nanoparticles, they're able to do that because they actually end up in the microcapillary beds of your body. Yeah, they make their way to the microcapillaries of your lungs, of your heart. And the issue with that is you're having non-specific expression of S-spike proteins on your cells.
Yes.
The issue with that is, for example, your dopamine receptors, you have dopamine receptors in your brain, but you also have them in the breast. That's how a woman lactates, and gets, or if, and then if you've got, a woman has dopamine receptors also in her stomach lining, which is what triggers the morning sickness when HCG hormones released. So the dopamine receptors yielding a different response depends on which cell types are expressing it. Now, if we have S protein just expressed randomly and arbitrarily on any cell types in our body, that's going to yield a different response, which is why we're seeing the myocardial inflammation, the pericardium inflammation, the clotting. I just think that it goes all against the principles of precision-based medicine, or you can't just pan express a protein all on your cells non-specifically.
Yeah. Well, I think
and that's where my hesitancy in taking the vaccine. Otherwise, I would have just taken it by now. The traditional vaccine was just to get a little bit of the virus in you, and you just built an immune response against it.
Yeah, I think the production of the spike protein is going to be short-lived. It's not going to be for, it's going to be a few days, I'd imagine. But you're right. I mean, there's going to be billions of spike proteins potentially produced all over the body. Yeah.
Okay, so it's short-lived. Is that what makes it like not so bad after all?
Well, I mean, yeah, I mean, that's right. Because mRNA has got a very short half-life, so the mRNA will be broken down. So what you'll find is that these particles, the mRNA is in a lipid capsule, and so basically it'll circulate. It can't. So normally mRNA, if it's loose in the tissues, it will be broken down very quickly by mRNAs. Within seconds to minutes. Yeah.
That's why you have to package it with the nanoparticle. That's the whole point of the carrier, to get it to the cell.
That's right. That's right. And then, so it can't break down in the bloodstream. So if it exits away from the muscle side where it's injected, then it's going to traverse through the bloodstream and then enter cells, randomly.
Okay. So that was my fear with it. And then that's the mRNA is okay. The Pfizer vaccine is just based on principles, is a lot easier and safer. I mean, those nanoparticles, they have their own kind of nanoparticles on their own without any mRNA in them, have their own issue. They're like soap. It's like injecting soap in you. It's sort of the compound they use to make detergent, but that's a different issue. But then this AstraZeneca one goes another level. It's actually a double-stranded DNA injected into an adenovirus. The adenovirus gets taken up by any of your cells. Then it enters the cell nucleus. The DNA, double-stranded DNA, releases into the cell nucleus and then transcribes the S protein and finally takes it to the cell surface. I just think that extra step there is dangerous.
Well, look, I think the idea of the adenovirus is it is a little bit more targeted towards the nasopharynx, because that's why they've used the adenoviruses, because adenoviruses do tend to sort of target specifically towards the nasopharynx and the respiratory airways.
So the AstraZeneca vaccine is more targeted. Is that what you're saying?
Well, because it's using an adenovirus to deliver. Yeah, I mean so the mRNA.
Upper respiratory airway or something. Is that where it's going?
Yeah, that's right. But of course the difference. Yes, you're making some very good points. The difference is of course adenovirus. Of course, when it's delivered normally in the normal state of affairs, it's delivered as an aerosol, and it's delivered through into the respiratory tree, and from there it's taken up into the cells. So the adenovirus is when it's injected, of course, it's a different route to get to the nasopharynx, and so consequently, the belief is because it's an adenovirus, it will find its way to the nasopharynx and the upper respiratory tree, and thereby create the immune response, and also the local deposition of the adenovirus will start producing, as you say, the spike proteins, and then basically that will be taken up to the local lymph nodes. So that's the theory. But of course, again, I haven't seen
that's fine. In theory, that's fine. But then you have this double-stranded, like our transcription machinery is now transcribing a protein that does not endogenously ever evolutionarily live within us. So this S code doesn't exist in our genome. We are now transcribing it. We're using our own nucleus, our own chamber to transcribe this machinery. So I think, you know, transcription itself has so much risk on a day-to-day basis. That's how you get a missense mutation. That's how you get incorrect, you know, I mean, this is like that. You're opening yourself to another level of damage that could potentially occur. It's like the mRNA was one thing, but now we're going double-stranded DNA to make the mRNA and then go and turn it into protein. So
yeah, I think that yeah, you know, look, absolutely, it's impossible to predict the downstream consequences of this, and also the other thing you need to be aware of as well is that the mRNA, even though it's a single-strand mRNA, it actually it does form double-stranded mRNA as well, which can create its own toxicity and has unquantifiable downstream effects as well. So these questions are definite. I mean, these are novel nucleic acid vaccinations,
and then
I mean,
the next thing I wanted to say is Australia has committed itself to 51 million doses of the Novavax coming out. Now, I think I have a little bit more confidence in the Novavax form of the vaccine because it is the traditional way. It's basically a recombinant synthetically made S protein injected into you. It's tagged, or it's an adjuvant. So instead of being that traditional aluminium adjuvant, it's using saponin, which itself is toxic, but that's okay. It's mild form. And they just to get, you know, a boosted immune response, and then your T cells come there, and, you know, and your memory cells, and they make an immune response to the synthetic S protein. Would you say that's a better alternative?
It's much safer using proteins than DNA and nucleic acids. Yeah, I mean, nucleic acids are, you know, with proteins. I mean, there's two things about proteins. One is that if you have a protein vaccine, then the protein is broken down at the site in the muscle, and the protein, if it does enter the bloodstream, is metabolized very, very quickly in the bloodstream. So with nucleic acids can have different effects in different arenas, and so
in different cell types, and a cell could be already going through transcription at the moment, and then that double-stranded DNA comes in and accidentally gets incorporated. I mean, I just see so many chances of something going wrong. The chance of error just goes up and up when you're doing that.
Oh yeah, I agree. I think you're right.
Okay, so do you think, because eventually we need to work, we have careers, we all have mortgages, we have homes to pay off. So we need to somehow find a way. So what do you think if we take the Novavax when it comes out? Hopefully it'll get TGA approval by the start of next year, March sometime.
Well, I mean, I haven't seen the details of the Novavax, but I mean, protein vaccinations are what we've dealt with in the past. I mean, we've got over a century of experience with protein vaccinations, and they've been very, very successful modalities.
And okay with saponin as an adjuvant? I mean, for so many years you had all your anti-vaxxers hating aluminium, but I don't think it's that bad, aluminium, that in microscopic amounts in the vaccine, because you consume more aluminium just by drinking water from the tap over your lifetime.
Yeah. I mean, I think using local adjuvants, I mean, it's only going to be a very small dose of adjuvant
so
locally.
So the saponin is okay, you think?
Look, I haven't seen the data in detail, but I would have more. I certainly would. I agree with you. I
think the Novavax is the best option. Okay, and just one more thing I wanted to say was thank you so much. You actually gave me really good insight. Actually, I didn't know that the adenovirus made its way to the upper respiratory tract. So that was really informative to know that.
Yeah, well, I don't know whether that happens for sure, but that's what's supposed to happen.
Yeah. So I think eventually it's going to be, the other part I wanted to tell you. So there's also molecular mimicry. So the S protein, that's why what happens is you have little clots happening inside of you all the time, your microcapillary beds.
Yeah.
Now platelets come in and they clean up that mess. And what's happened is with those people who have developed the clots, especially one obstetrician at the Mount Sinai Hospital in California. He's a renowned obstetrician. He died 16 days later after taking the COVID vaccine. He developed a complete shock and platelet attack. So basically they kept pumping him with platelets and he just would show 0 levels of platelets when they do the blood test. And basically the S protein was similarly in structure to his actual platelet. There's a protein on the surface of the platelets that mimics a little bit the S protein, the spike protein. And that, well, you're getting an autoimmune attack. In his situation, it was on the platelets, and he died within 16 days, entered coma and hemorrhaged in his brain. So, so molecular mimicry is the other issue we have with S protein. So yes, we might have it for a few days expressed on our cell surface, but that immune, you've just made T cells against that structure, and that structure might look very similar to something else that lives endogenously in your body, and therefore you have an autoimmune attack on that part of your body.
Well, the spike protein shares a lot of homology with platelet factor 4. One of the proteins in the clotting cascade.
Oh, it is platelet factor 4.
I'm just going to jump in for a minute, Arif. I have to go. So thanks to everybody.
Thanks so much for your time,
for being on board, and I hope to catch up with you all again very soon.
Thank you.
Thank you, Joe.
Bye.
Bye. Yeah. So it shares homology with platelet factor 4. So the theory is that it can trigger the clotting cascade and lead to that's how it potentially leads to blood clots.
Sure.
Yeah. Everything in nature is recursive. So very few proteins are unique. They share patterns and
exactly, and it's normal to have So that's the other hesitancy I have with the vaccine, just that autoimmune response. And yes, some people showed a shocking autoimmune response straight away. But I honestly believe, because there's booster doses, that 85 million doses have just been shipped to Australia or organised for next year to be shipped. They're obviously planning to jab us another 4 or 5 times. So it may not be the first hit, might be the second or the third or the fourth hit.
Yeah.
Yes.
Anyway,
thanks for sharing. Sorry, David.
Thank you so much. Sorry I took up time, but these are questions that have been pondering in my mind, and I'm glad you answered them. Thank you.
Yes, and hopefully you'll join us for the vaccination forum in a few weeks.
Yeah, has anyone taken it yet, or are they planning to, or what's going on?
Sorry?
We'll come out and advertise it soon.
Yeah.
Pardon?
Health Rights Alliance will come out and advertise it soon when we've set a new date.
Sorry, last question for Sonia. Can we unmute her? Thank you.
Should be unmuted now.
Yes. Oh, sorry, let me take that off. Yes, hello, this is Sonia. I'm currently overseas in Japan, and thank you to everyone for all the amazing input and information. And I'm glad the previous lady went into all the mRNA information as well. This is kind of half question, half really serious concern. The fact that from all these tests with the AstraZeneca, Pfizer, I've been on other Zoom calls with people in America, in Europe, doing lots of research. I'm not a doctor, but I have a little bit of a medical background, but I just have been doing copious studies and research and reading people's documents. And even the last few weeks, I've come across some stuff from Italy, from Israel. I was online with a guy who works in an elderly people's home in California. And though, you know, the vaccine's supposed to be helping people of elderly people, he said he's been working there for years. On average per year, they're like, if they have 14 elderly deaths a year, they've been getting 14 deaths a week. And some of the staff who got the vaccines also passed out and died. The fact that there's been no blind test studies done on all of this stuff. One group I was talking to, there's over 177 different vaccine types. My biggest concern is that we are the lab rats, and people should be concerned that how do we even deal with this, even from a legal standpoint of view, let alone a medical point of view? I know various people personally who have died or have developed like multiple sclerosis type symptoms. Another friend of mine who's a young couple, the man now has no erectile function, all kinds of stuff like that. But the fact that none of the contents of these vaccines are being, the pharma companies have actually been given permission not to have to disclose anything. We have no legal rights to sue them for anything. And they pay all these mRNA genetically modified stuff, if you do your research, is patented in the New York Global Patent Office. And as such, while you cannot patent human cells, you can patent medically modified GMO cells. So now anything that's injected into you, and if you read the documents, actually makes you not a human anymore, but a transhuman. You no longer have any human rights as a transhuman. There's all these other legal issues, never mind that people are dying all over the world. You know, in past studies with other medical research for anything, whether, you know, as soon as a lab rat dies or a dog dies where they're doing, you know, experimentation to check, they would automatically say, no, you've got to go back to zero. You know, the animals are dying. Here, people are dying globally in Australia, in Europe, all over the place. The Pfizer accounts from the doctors in Israel are staggering. And the information they're saying of how it affects the kidney, the liver shutdown, the heart inflammation and all that. And yet people are still saying, I don't know whether I should be taking this or not. And I'm thinking, why are we not challenging these corporations and saying we have no legal rights? We are the lab rats. So to me, like, what can we do? You know, we need to kind of come together to figure out how we can address these issues, because the fact that even one person died should be of concern, but thousands of people are dying or being medically injured. And we're all okay with this. And I heard our illustrious Prime Minister saying yesterday on a news, or the day before on a news report, saying, oh, look, you know, it's your responsibility. You don't have to take it, but we're actually being coerced to take it. And if you don't take it, you're going to get the passport and you can't go shopping and you can't travel. So we're being coerced. There's all these complex issues that are really overwhelming. How do we even address that?
Well, I think that data from Public Health England is the most compelling data, because you know, it quite clearly shows that if you have the vaccine in England, that your chances of dying from the Delta variant and from COVID are less if you're above the age of 50. And I think that that's the most solid data I've seen in respect of the effectiveness of the vaccine.
Yeah.
I looked at the data. I did look at data in January and March in Europe, and I looked at there was an increase in mortality rates in January and March through Europe, and I looked at 29 countries through January and March, and I looked and tracked to see if I could see if there was any relationship between the increased deaths in January and March and the rollout of the vaccinations, looking at 29 different countries. So if you're looking at 29 different countries, you should see an effect. If there was an effect of the vaccine increasing mortality, certainly significantly, then you would expect to see it across the different countries. And I couldn't find any relationship between the excess deaths in January or March across 20 European countries. Also, the American data, I looked at 40 states in the USA, and there was no increased mortality linked to vaccination rates across any of the 40 states in the USA. By the way, I looked at one single shot vaccinations. I looked at 2-shot vaccinations, fully vaccinated, and single vaccinated. So although you know, there could be low rates of death related to the vaccine, and you know, certainly the European Medical Agency, which is one of the best repositories in the world, acknowledges that there is a small, you know, sort of, you know, 400,000 risk of death. It was temporarily related to the delivery of vaccine. You know, what we're seeing is quite clearly a health benefit in vaccinating people over the age of 50. And that could be honed in, you can look at different subgroups with that as well, but I haven't got that information to be able to improve that information. But I think the question that the previous person was asking about was, what are the long-term ramifications of nucleic acid vaccinations? And we don't know. We don't know what the long-term, because they're novel vaccines, and so I think if you're in that age group where it's been shown that there's a mortality benefit, then it's worth considering the vaccine, because it will protect. And I mean, what it's telling us is that if you're over 50, according to the Public Health England, if you're over 50 and you get the vaccine and you get coronavirus, you're about 3% less likely to die from the coronavirus if you've had the vaccine than if you didn't have the vaccine. But that's only with people over the age of 50, over 50 years old.
Yeah, look, I hear all of that. I guess my biggest concern is that, we've got a lot of anecdotal evidence from actual hospitals, from doctors personally. I know of one doctor in Atlanta, Georgia, who she's used chloroquine from the very beginning, and every single patient, even people who are like on their death's door within 4 days, actually survived and recovered and all the rest of it. A lot of this stuff's hidden. My concern is the fact that there are any deaths from these not yet approved of experimental, because that's what they are, they're experimental drugs. The fact that your chances of surviving COVID naturally, the fact that we're saying, well, your rates of, we're giving percentages, but the fact that anybody died from these vaccines and everything's all in experimental stage, and the fact that the pharmaceutical companies are being given exemptions from any legal liability, we should be really concerned about all of this.
Yes. yes.
And why would you take it? It's like, okay, so we can all die. You don't have to be held accountable. The governments aren't being held accountable. And okay, well, maybe 50 people died. The fact that even one person died, this stuff should be stopped, because the chances of the majority, we already know that the majority of people are going to survive. And it's being forced on people. That's my biggest concern. And how do we get around it? Because to me, it's all a political ruse. And I don't want to get into the politics, but it's devastating.
Yeah, I mean, look, I think the thing is, you've got to go to trusted authorities in terms of trying to identify the information, because it's very difficult to quantify these things.
For sure.
Yeah. And I think that the EMA, the European Medical Agency, is well, in fact, the Dutch keep one of the best kept repositories in the world, and so the mortality rates reported there, I don't have any reason to doubt the integrity of the data kept in the Dutch repository, and that shows that demonstrated as I say, a 4 in 100,000 risk of mortality linked temporarily to the vaccine, not necessarily caused by the vaccine, but that's associated with that. And so it gives you some reassurance, because when you look at those kind of mortality rates and you compare them to the COVID mortality rates in people over the age of 50, then it gives you some reassurance that COVID is definitely more toxic to people over the age of 50. Where it does become a problem is when it does become a problem is when you again people who are children, people between 12 and 18 and young adults, when they're expected to get a vaccination, when there's clearly minimal benefit in them receiving in terms of their immunity, and then that there is vaccines, as you say, they're not sort of without risk, then of course that seems wrong. It seems wrong that we should expect people who have got no risk of the disease, and as you quite right, as somebody pointed out, the question is would the vaccine, giving the vaccine to young people, would that help to protect immunity overall by stopping the spread of the infection to older people? Well, as I said, from the European data that I looked at, the reduction in transmission of the infection was very small compared with the, it was 200 cases a day out of almost 3,000 cases a day. So it's not going to significantly affect viral transmission rates through Australia. It's not going to be effective for that. It's the individual benefit that it gives to older people. And Brendan Murphy, the health secretary to the health ministry, said the same thing, that basically the purpose is to protect the vulnerable and the elderly, and they've done a good job of that already. And quite honestly, I think Brendan Murphy was exasperated by the state politicians who are just using vaccinations. They're literally using vaccinations now to justify their control
Their
measures.
agendas. Yep. Thanks very much. Yeah, I
No,
appreciate your answer.
Thanks, everyone. And we'll wrap up here, and hopefully we will get to talk to all of you again in the future.
Thank you.
Thanks so much, everyone, for coming. Just make sure that you're signed up to our mailing list, which I've just put in the chat. Most of you should be already if you have registered online, and you will receive a recording of this session sometime over the next 24 hours, probably. And we will make sure that you get emailed to inform you of the next session in the series. Thanks so much for supporting us and supporting these fabulously brave doctors who are speaking out.
Thank you.
Thank you.
Everyone.